Bismillahirrahmanirrahim. Assalamu alaikum. Today we are going to discuss a case of cilioretinal artery occlusion. Seema Bibi, a 74-year-old female housewife resident of Lahore, presented in the outpatient department of Mughal Eye Hospital on 3rd October 2023 with presenting complaints of sudden, painless decrease in vision of right eye for 10 days. She was hypertensive for last 18 years, for which she was taking oral antihypertensives. She was also diabetic for 18 years, but she was not taking any medications for her diabetes. Past medical and surgical history was insignificant, and family history was also insignificant for any ocular or systemic disease. She was taking topical lubricants for dry eyes, and there was no history of using spectacles, ocular surgery, or trauma. On examination, her visual acuity in the right eye was hand motion and left eye was 6 by 12. Best corrected visual acuity was still hand motion in the right eye and it improved to 6 by 9 in the left eye. Lids, conjunctiva and cornea were within normal limits. Anterior chamber was deep and quiet in both eyes. RAPD was positive in a right eye, whereas the pupil was round, regular and reactive in the left eye. There were some lenticular opacities in the right eye and nuclear sclerosis grade 2 in the left eye. Intraocular pressure was 17 and 16 millimeter of mercury in right and left eye respectively. On examination of fundus, in the right eye there were splinter hemorrhages and exudates around the disc, along with blurring of the disc margins, more prominent nasally. There were tortuous vessels in the superior and inferior arcades, and a cherry red spot was seen with a patch of retinal whitening extending from the optic disc to the macula. The fundus examination of the left eye was within normal limits. This is the fundus photograph of the right eye of the patient, in which we can see various splinter hemorrhages around the disc, along with some exudates. There is tortuosity of the vessels in the superior and inferior arcade. We can see a patch of retinal whitening extending from the disc to the macula. This is the red-free photograph of the same eye, in which the splinter hemorrhages around the disc are more prominent, along with a few exudates, and a retinal whitening along with a cherry red spot is also more appreciated in this red-free photograph. This is the fundus photograph of the left eye, which is within normal limits. We ordered few investigations, which included a fasting lipid profile, HbA1c, and serum PT and APTT levels. Based on history and examination, our differential diagnoses are cilioretinal artery occlusion due to the presence of retinal whitening in a patch extending from the disc to the macula along with the cherry red spot. Central retinal artery occlusion is also in the list, but as the peripheral retina was normal, so it is down in the list of differential diagnosis. Commotion can also be a differential, but commotion retinae is basically a traumatic retinopathy which occurs due to the blunt trauma, direct or indirect to the globe. When the commotio retinae involves the posterior pole, it is known as Berlin edema. Pseudo cherry red spot is also seen in commotio retina, which is involving the posterior pole. So it is also in the list of differential diagnoses. Lysosomal storage disorders, which include Tay-Sachs disease, Niemann-Pick disease, and gangliosidosis, in which a true cherry red spot is seen due to the presence of lipid-containing substances in the retina. And the fovea is paired, which appears to be cherry red. Macular hole also mimic a cherry red spot. So our probable diagnosis upon history and examination is cilioretinal artery occlusion. Ocular massage was done in the outpatient department, and topical beta blockers along with carbonic anhydrase inhibitor were given 2 times a day for 2 weeks. Patient was referred to a neurologist and a cardiologist for further investigations and workup, and he was called for follow-up after 1 week along with the reports. We will briefly discuss about the cilioretinal artery. It is present in about 1/3 of the eyes. It is basically derived from the posterior ciliary circulation. Posterior ciliary arteries are they arise from the ophthalmic artery. The posterior ciliary artery gives the cilioretinal artery, which provides central macula with the second arterial supply. The main arterial supply of the retina is a central retinal artery. When there is cilioretinal artery, it facilitates the preservation of the central vision after central retinal artery occlusion. This picture briefly shows the division of the ophthalmic artery. Ophthalmic artery is basically a branch of internal carotid artery. The ophthalmic artery enters the optic canal along with the optic nerve and gives off its first branch, which is the central retinal artery. Other branches which arise from the ophthalmic artery are short and long posterior ciliary arteries, lacrimal artery, supraorbital artery, supratrochlear artery, and the anterior and posterior ethmoidal arteries, along with the muscular branches of the ophthalmic artery, which supplies the extraocular muscles. So the short posterior ciliary artery, which supply the sclera, choroid, and it also gives off cilioretinal artery in 1/3 of the people. Cilioretinal artery occlusion accounts for approximately 5 to 7% of all the retinal artery occlusions, and it is usually associated with central retinal vein occlusion or anterior ischemic optic neuropathy. Isolated cilioretinal artery occlusion can also occur, but it is rare, but it is present in our case. Isolated cilioretinal artery occlusions typically have a better visual prognosis than those which are associated with central retinal vein occlusion or anterior ischemic optic neuropathy, with 90% of the patients achieving a visual acuity of 20/40 or better. When cilioretinal artery occlusion is combined with anterior ischemic optic neuropathy, it usually affects the patient with giant cell arteritis, and it carries a very poor prognosis. The main etiology of retinal artery occlusion is basically due to emboli or vasculitis, which is more in young patients, or spasm of the retinal arteries. Occlusion of the ophthalmic artery is often due to giant cell arteritis, whereas occlusion of the cilioretinal artery, it is mainly secondary to central retinal vein occlusion due to increased outflow resistance in CRVO. This is a picture, a fundus photograph of the right eye of a patient, in which we can see there is retinal whitening which is extending from the disc to the macula. Rest of the fundus is normal, and cherry red spot is also seen. This is a case of cilioretinal artery occlusion. The critical period of cilioretinal artery occlusion is it is experimented in primates to be 4 hours, in which there is a good prognosis if it is reverted within 4 hours. No such study is carried out in humans, but it is postulated to be 6 hours due to some studies which are carried out on tissue plasminogen activator. And tissue plasminogen activator basically thrombolize the thrombus, and its effect lasts for if the thrombus is formed within, if the thrombus is thrombolized within 6 hours. Treatment of cilioretinal artery occlusions include ocular massage. It can be done in the outpatient department and can also be done by the patient at home. It is basically done with a contact 3-mirror lens, which is placed on the globe, and the lens is pressed for 10 to 15 seconds, and then it is released, and it is continued. This massage is continued for 3 to 5 minutes. The aim of ocular massage is to basically mechanically occlude the retinal arteriole in order to increase the perfusion and to dislodge the embolus or thrombus by the massage. IOP lowering can also be done, which has an effect in increasing the perfusion of the retinal arteries. It can be done by topical as well as intravenous carbonic anhydrase inhibitors. Topical beta blockers can be given to lower the intraocular pressure. Rebreathing can be done through mask or paper bag, in which what happens is that the patient breathes its own carbon dioxide. The carbon dioxide which enters the body, it dilates the vessels, and vasodilation occurs, which can cause increased perfusion of the retinal arterioles. Then carbogen mixture is also done. The carbogen mixture is also used for the treatment of cilioretinal as well as central retinal artery occlusion. Carbogen mixture is basically composed of 95% oxygen and 5% carbon dioxide, which is inhaled by the patient, and it has a dual effect of increasing the vasodilation as well as it relieves the ischemia. Sublingual isosorbide dinitrate can also be given. It increases the vasodilation. Hyperosmotic agents like mannitol can be given. It rapidly decreases the intraocular pressure as well as it increases the intravascular volume, thus improving the ischemia. Transluminal anti-YAG laser embolysis or embolectomy can be done in patients who have central retinal artery occlusion or branched retinal artery occlusion, in which anti-YAG laser shots are given to the area of the artery in which thrombus can be seen, and the thrombus is then ejected into the vitreous, but it has a complication of vitreous hemorrhage or subretinal hemorrhage, so it is not routinely used. Thrombolysis can also be done, as it has proven benefits in myocardial infarction and stroke, but there are multi-center study was carried out in which they were seen that there is no added benefit in retinal artery occlusion. Systemic management is done, in which the patient is referred urgently to cardiologist and neurologist, because these patients have a high chance of underlying stroke and coronary ischemic events. Patient is asked to stop smoking, as it is a risk factor for artery occlusion. Antiplatelet therapy can also be initiated after consulting the physician, and if patient has no contraindication to antiplatelet therapy, immediate dose of 600 milligram of antiplatelet are given to the patient. Oral anticoagulation, for example, warfarin, can also be given to patients who have concurrent atrial fibrillation, and carotid and endarterectomy can also be performed if the patients have symptomatic carotid stenosis on carotid Doppler, and carotid stenosis is of more than 70%, then carotid endarterectomy can be performed. So this is basically a mnemonic for cherry red spot. Cherry trees never grow tall. See central retinal artery occlusion and cilioretinal artery occlusion, Tay-Sachs disease, Niemann-Pick disease, Gaucher disease. These are all lysosomal storage diseases. And trauma, for example, commotio retina involving the posterior pole, that is Berlin edema. Thank you.
का इमेज लेगा, तो जब भी इस तरह का कोई रेटिना का केस है जिसमें लीजेंस आप, तो इनडायरेक्ट बोले टाइम हो तो करे, अगर टाइम नहीं है लिमिटेड टाइम हो तो मेंशन।
So you see, this patient had cherry red spot and hemorrhages and exudates. So can cilioretinal artery occlusion diagnosis explain all these three findings? No, there are no hemorrhages and exudates in central cilioretinal artery occlusion. So whenever we make a diagnosis in a case, we keep in view all the findings of the case. So what would be the provisional diagnosis in this case? A diagnosis which can explain all or most of the findings. Okay, this is one option. Anything else? What was the age of the patient? Okay, the age is also goes in favor. So diabetes and hypertension are the most common causes of these problems. So my diagnosis, provisional diagnosis at the top of the list would be diabetic retinopathy with cilioretinal artery or hypertensive retinopathy with cilioretinal artery occlusion, right? So you do not make diagnosis on one finding. You keep in view all the findings and then make it. Similarly, you said in the differential diagnosis, Berlin's edema, traumatic. So you did not mention history of trauma in the history or not. So you said smoking should be stopped. So you did not mention there was a history of smoking or not. See, when you present the case, you take the history, then you consider differential diagnosis, then you again ask some questions, and those should be included in the history. Your history was very catchy, only 2 lines. It should be detailed. Whatever differential diagnosis you have considered should be reflected in the history also. So you make a list of probable diagnosis keeping in view the history and the findings. And then you ask for investigations. So what investigations did you do? So you did not show any slide of investigations. You see, this is not a properly worked up case. We cannot sort of present this case at any forum. We cannot publish this because it is incomplete. So, keeping in view the differential diagnosis, you advise investigations. And in the light of investigation, you reach a diagnosis, whether it is diabetic retinopathy. See, the hemorrhages and the exudates go in favor of either diabetic retinopathy or central retinal vein occlusion, because the exudates and hemorrhages are feature of venous occlusion. If these two findings are present in both fundi, then it is most probably diabetic or hypertensive. But if it is in one fundus, then it's most probably a venous occlusion. So you should have searched the Google and the PubMed to see if the cilioretinal artery can also be combined with venous occlusion. So there are reported cases in which venous occlusion and arterial occlusion have occurred simultaneously. And what are the features? So you need to have FFA, you need to have OCT. So unless you do the investigation, how can you reach a definite diagnosis? You see, and then when you reach a diagnosis, you tell what you have done in this case. You did not tell anything. You did not advise cessation of smoking, or was he on antiplatelets or anticoagulants? You did not mention. You see, the history of trauma you did not mention. Similarly, you send the patient for carotid angiography, or you palpated the carotids, thrill, bruit. You ask for echocardiography, but you did not mention that the patient was sent to cardiology department for. Ideally, these investigations should be part of presentation, that we did the CVS workup and the carotid artery was blocked or open, whatever it, because there is an element. You see, the emboli are coming from either heart or carotid. So you have to see the source from where these are coming. Patient survives one episode, then next day patient may have another episode. So the treatment includes the prevention of further attacks, right? And you have to have a short follow-up whenever you present a case or publish a case. You tell that I followed up the case for 2 weeks, 4 weeks, 2 months, and this happened. So yeah, it was not expected out of you. You are a very bright student. Please give some time and energies to prepare a case. This is a very, what can I say? It should be detailed case preparation. Right. And you have to discuss the cilio-artery occlusion in combination with the other phenomena. You just Google or add search in PubMed and you will have a lot of articles. The cilioretinal artery. You see, you have considered differential diagnosis like Niemann-Pick disease, lipid storage diseases, but you did not mention anything in the history. You have to exclude the differential each entity by asking in the history and then in the examination. Then you can exclude the. How can you exclude the lipid storage diseases? So you have to mention, you have to justify, you have to make a case that this is the diagnosis by proving that the others are wrong. Right? Any other comment or question?
اس میں میں یہ عرض کروں گا آپ لوگوں سے کینس کی ٹیکسٹ بک بہت اچھا ہے آپ لوگ پڑھ رہے ہیں لیکن لیٹ سے جب آپ لوگ کیس پریپیئر کریں تو اور جب آپ کے ذہن میں ہو کہ ہم نے یہ کیس پریپیئر کرنا ہے تو ولز جو ہے ایک مرتبہ اس ٹاپک پہ ولز کو پڑھیں اور اس ولز کے جو پوائنٹس بنائیں اس کو یاد کریں ان پوائنٹس کو اپلائی کریں تو آپ کمبائنڈ ٹیکسٹ بک آپ کے ذہن میں رہے گی اس کے اندر ہے لیکن وہ آپ کو اس اپروچ کے ساتھ لے کے نہیں چل رہا ہوتا جتنا اچھا آپ کو ولز لے کے چلتی ہے اس چیز کو ذہن میں رکھ کے اینڈ دین وانگ از آلسو گڈ تو ولز اینڈ وانگ یہ دونوں اگر آپ کمبائن کر لیتے ہیں اینڈ دین یو پریپیئر دا کیس آپ کوئی چیز مس نہیں کریں گے کچھ چیزیں اس میں سے اور پھر آپ کی بیس تو ماشاء اللہ کینسل کی جائے تو پھر آپ چیزیں مس نہیں کریں گے کیونکہ یہ دونوں چیزیں وانگ اور ولز یہ آلموسٹ ساری چیزیں کور کر لیتی ہیں.
And the point is that you have to consult some senior.
جی
آپ نے کسی سے ڈسکس کیا تھا یہ بیٹھے ہوئے ریال صاحب یا باقی اگر ہم لوگ نہیں بھی اویلیبل تو یہ سینئر آپ کے پاس ہیں امیڈیٹ سینئر ہوتا ہے اس سے آپ طاہر صاحب. سو کہنے کا مقصد ہے کہ ضروری نہیں ہے کہ جو ہم سینئر موسٹ بندے ہیں ٹھیک ہے ہم اگر اویلیبل نہیں ہیں تو ڈاکٹر آمنہ ہے یو اپنے کولیگ سے ڈسکس کریں اور جب بھی آپ 2-3 بندے مل کے ڈسکس تو بہت ساری چیزیں ہو جاتی ہیں. سو اس میں بہت زیادہ ڈیفیشنسیز رہ گئی. ہاں مطلب ہے یہ چیزیں جو ہے نا اس کو تھوڑا سا کریں. وہ ڈاکٹر نور تو وہاں پہنچ گئی تھی پریزنٹ کرنے مری میں تو آپ تو یہاں پہ تو کم از کم اچھا پریزنٹ کریں نا تو
I think he was